Wonderful. Thank you so much. Welcome everyone this afternoon. We really appreciate that you've taken the time out of your Monday afternoon to come and sit with us and sharing some knowledge that Annie Bleeker is going to share with us around emerging drugs and drug trends. I'd just like to start with acknowledging the rich cultural and spiritual connections of the Aboriginal people on the many lands in which we gather today. I'd also like to respectfully remember the footsteps of the ancestors who have walked this land before you and I, and for all of those who will follow, and also recognise those in the room who do identify as First Nation people. So thank you very much for sharing your time with us. By all means, as we go forward from here, feel free to flick your cameras off. If you've got any questions, use the chat bar. We'll be interrupting Annie politely as we go through, but thank you so much, and over to you, Annie.
Thank you very much, Gail, and thank you again, everybody, for attending today. Just by way of introduction, I'd just give you a little bit of information about myself. So I've been working in the alcohol and drugs sector since 1990, so that's coming up to 32 years. I've spent a lot of time for the last probably 20 years or so, doing a lot of community education, but I also spent about 8 years doing research and about 2 or 3 years working over in the Netherlands, and also spending a couple of years working in Indonesia doing education and training there. Basically to upskills workers to understand harm reduction principles, which is a really important practice and great skills to have. So this is the first of 4 modules, and this is very much going to be an introduction about alcohol and other drugs. We will, the next session will be talking about alcohol, cannabis, and nitrous oxide, and also vaping, which has been really, pertinent, I think, particularly very big rates in the 18 to 24-year-old age group. About 1 in 4 have tried vaping. And then the next session will look at psychostimulants, which is basically MDMA, cocaine and methamphetamine. And the last session will be all about overdose prevention. So this is very much, as I said, an introduction to alcohol and drugs. We'll be looking at some key terms and context. And I apologise for those of you who have done a little bit of drugs work already and know a little bit more about it. So it's, I guess, a bit of a drugs 101. So similar to Gail, I would like to acknowledge the traditional owners on whose land we're all meeting today. I'm speaking to you from Bundjalung country up in the Northern Rivers, and I would like to acknowledge the First Nations people as the traditional owners and custodians on the land we're meeting, and pay respects to elders, family and ancestors, and extend that particularly to any Aboriginal people that are online with us today. I would also like to acknowledge all the people with lived experience in this area, be that with alcohol and drugs or with mental health. And I trust that the information I'm sharing today doesn't trigger you with anything in particular, but please make use of Lifeline if that is the case. So what are we going to cover today? Well, we're going to look very much at alcohol and other drug trends in New South Wales and Australia, and I've got comparisons of the data from the whole of Australia versus what's happening in New South Wales, just to see where we fare in relation to others. Some areas are better than others. Alcohol use is less than places like the Northern Territory. We're also going to spend a bit of time talking about some of the harms related to alcohol and drugs. And then we have an activity called the Concernometer, which we'd normally do because there's online. We might do this as an activity all together. So as Gail said, please put through any chats or comments that you have, and Gail will keep an eye on the chat function and interrupt me if we need to. Or call out yourself if you want me to clarify anything further. So the first thing I will do is set the scene with you. Now, this is asking you what drug this is. And this was written by Cambridge Regis and Professor Albert and W.A. Dixon about 115 years ago. And it states, the sufferer is tremulous and loses his self-command. So my apologies for the gendered language in this quote. He's subject to fits of agitation and depression and has a haggard appearance. As with other such agents, a renewed dose of poison gives temporary relief, but only at the cost of future misery. Can anyone tell me what drug they were talking about? And remember, it was 115 years ago, so it's more some of the old school drugs rather than ones that are been around for the last 30 or 40 years. Has anyone got any ideas? No one's saying anything. Okay. Well, most people think it's alcohol. Many people also might guess that it's opium or laudanum, which was around during this time. But in fact, it is coffee or caffeine. Now, why are we talking about this drug? Well, I think it's a really good place to start because in a lot of ways, you can see that the stigmatization of drugs has been around for a very long time. And stigma and discrimination, as we'll talk about a bit towards the end of this webinar, is really kind of critical to be aware of because it actually stops people from accessing alcohol and drugs treatment. So you can see how much this guy who was around in the UK in 1700s to 1800s, what he thought of caffeine. He was actually particularly talking about tea in this quote. He was really upset about tea taking over the alcohol market. So people were starting to drink tea instead of alcohol, which is how they used to start their day. Not that anyone got anything particularly done at that time. But it's quite interesting because in 1675, King Charles II basically tried to ban caffeine because he sort of saw it as a threat to popular society. And that's because when people went and had coffee or tea, they went to what was called coffee houses, which were dubbed penny universities. And the reason they were dubbed that is because, you know, these were places where sort of like commoners, as they were called then, could mix with people of sort of more highbrow, status in society, and they could exchange ideas and feasibly they could plan a revolution. And so these were very much seen as places where new scientific thought and philosophical thinking was happening, and these were seen as countercultural. As we all know, caffeine is the most widely used drug, psychoactive drug in society. We actually had a death relating to caffeine a couple of years ago. So this was a guy in 2018 who was estimated to be a teaspoon of caffeine powder in his protein shake. He had no other drugs on board, and basically he ended up having a cardiac arrest and dying. So as a result of this, Australia banned the sale of pure caffeine powder. So you can basically overdose if you have too much caffeine. If we were to drink it in coffees, you'd have to have between 50 to 100 coffees in a very short period of time for that to result in overdose. Caffeine is in many energy drinks, as we know. It's also in Coca-Cola. It's also found in chocolate. So we have some guidelines or harm reduction, what we would call guidelines around caffeine, which would say that an adult over the age of 18 can have up to 400 milligrams of caffeine per day. So one espresso coffee, for those of you who need a coffee in the morning to get started, myself included in that, contains about 100 milligrams of caffeine. So that's an espresso coffee. If you have an instant coffee, that's more likely to be 40 to 60 milligrams. And the reason that people often need caffeine in the morning is because they've gone into withdrawal overnight. And so their body is craving a hit of that caffeine to kind of like function. There's probably people online that may well have tried to give up caffeine at a time and had pretty bad headaches. That's the most, the biggest withdrawal symptom that people struggle with trying to give up caffeine. And so what they recommend is if you want to withdraw from caffeine, you do that over a really small, a long period of time and reduce the dose gradually over about 4 to 6 weeks to avoid some of the withdrawal that happen. So we recommend for children and adolescents, they shouldn't have more than about 100 milligrams of caffeine per day. Now, some of you might be working with clients who are using Red Bull or Mother, and the small cans of it, the 250 mils, they contain about 80 milligrams of caffeine. So we would recommend not having more than one small can a day if you're consuming it as a young adult. We don't recommend caffeine is consumed for people that are pregnant or breastfeeding. And, you know, as I said, overdose is rare, but it can has occurred in very high doses and it can be fatal, but that's more likely to happen with powder. So what is a drug? Well, this is the definition that we use in the field for it. It was developed by the World Health Organization in 1982, and it basically covers legal drugs like caffeine and alcohol and cigarettes or nicotine. It covers all the illicit drugs, of which there's up to 1,100 of those these days, and I'll talk a little bit more about that today. So, you know, the most common ones being, you know, cannabis.
Yeah, I'm happy to take that slide out. Yeah.
Can someone turn their mute themselves there?
Correct me if I'm wrong. There's the peripheral nerve system as well, it's central.
Sorry.
Got it now. Yeah, we got it now.
Okay, thank you. All right. So basically, and then it includes also some of the of medical drugs, particularly, and we're having a lot of overdose deaths, which I'll talk about in module 4 of this, associated with pharmaceutical opioids particularly, but also Valium. So it's any drug that is psychoactive that affects the physical and or psychological function. And that's the definition that we use. So why do people use drugs? Well, often when I put this slide up and ask people, you know, a lot of people will immediately say to avoid pain or physical and psychological pain. But the main reason that people use them is out of curiosity. So we conduct a survey, which I'll be talking about the results of shortly, in Australia, called the National Drug Strategy Household Survey. And in that, we asked people why they use drugs. And for the most part, it was to experiment or out of a sense of curiosity. So while many, and we think about this and apply it to ourselves, you know, the main reason many of us might have tried alcohol for the first time or even caffeine was really for a relaxation or enjoyment or to be part of the group. Sometimes it can be used to avoid physical or psychological pain. And this is particularly so with people that might have mentally ill health or experience some sort of trauma, particularly in their lives. But this is a group that are more likely to develop problems. And this is what we would talk about as risk and protective factors. And I think it's really important to note here that the vast majority of people who try drugs don't go on to use them for more than, you know, up to 5 years. So the time of our lives that we're more likely to use drugs is between the ages of 20 to 30. And it's a time before marriages and mortgages and babies. And it's a time at this age where we have a much higher disposable income usually, so more like a university time of our lives. And or we don't have other responsibilities like childcare and work, etc. But what are the risk factors associated with alcohol and drug problems? So this is what we talk a lot about in risk and protective factors in the alcohol and drugs field. So the opposite, you might have heard this saying before, the opposite of addiction is connection. So if people are disconnected from their families or from their communities or from their school groups or from their friendship groups, they're more likely to seek solace in alcohol and drugs. If they've been in abusive relationships, and the family is a really, really, really strong factor in this. So if they've grown up with violence, physical or psychological, if there's been, assault that they've also experienced in their lives, that can mean they're more likely to find solace in drugs. Trauma is hugely correlated with alcohol and drug use problems. So we find that 4 out of 5 people accessing drug treatment in Australia have some form of trauma. Now, most of us have been through, well, everyone probably in Australia or even in the world for that matter has been through COVID. And this is, brought out a lot of trauma in our lives. Now, and we did find when COVID first hit our shores in the first 2 or 3 months that alcohol use went up quite a lot in Australia. That seemed to level off as we got used to kind of living in the new normal. And this trauma can be a one-off event. Say you've, someone, like you lost a parent at a very early age, or you witness an accident, or, something more drawn out, like being in a war zone, or sort of sexual assault. Again, all of these type of impacts in our life, and the more of these risk factors you experience in your life, the more likely you are to end up becoming dependent or getting an alcohol or other drug use disorder. Mentally ill health, as I said, a lot of people use alcohol and drugs to deal with some of the symptoms and to cope with some of those symptoms. And we find this is quite highly correlated, particularly with people with schizophrenia. They might use cannabis to quell the voices, but the long-term prognosis with this is not good, because it means that people aren't necessarily compliant on their medications. And it's a bit like a credit card. You'll enjoy it now, but you'll pay the price down the track. If people are unemployed or can't find work, or they live in an area where there's high levels of unemployment, or they're bored, if there's high availability of drugs in the community, if they've got friends or even their parents are using drugs, then they are also more likely to be interested in drug use. So conversely, on the other side, if people are connected to their families and schools, they have, satisfying relationships, they haven't experienced trauma, their mental health is, fairly stable, they're employed, there's not a lot of high availability of drugs, and there's not a lot of drug use in their lives, then they're less likely to develop problems. And it's more likely to be what we would call, not that drug use can't be harmful on an experimental level, but you're less likely to become dependent on them. So a lot of there's also a bit of misconception that the first time you try a drug you will become dependent on it. That's not true. You'll have to use a drug a number of times like every day for a couple of weeks, or to actually become dependent on it. And that's when your system adapts to getting used to the drug and then has a withdrawal if you don't get it. So one of the other things we talk a lot about in the field, and you might have heard this yourselves, is the drug, person and setting. And this was basically or set refers to the person. And this was developed by Norman Zimberg in the 1970s. And what he did was looked at research into drug taking that included the person's state of mind, why they were taking the drug, and the real setting in which the drug use was taking place. This really makes up our sort of response to alcohol and drug use. So if we change any of these, like the drug, or the person's expectations of the drug, or the setting, it can result in a very different type of drug experience. So with the drug, we're talking about, is it MDMA? Is it, cannabis? Is it alcohol? How much of that drug is taken? If we take too much, obviously that can result in overdose. If it's swallowed or injected, or, sometimes people will shelve drugs, that's putting drugs up their anus. And a lot of times that is more likely to be done when people might have collapsed veins and they can no longer inject drugs, and whether or not those drugs are mixed with other drugs. And the person refers to, their gender, their thoughts and their moods and their expectations, their previous experience. Obviously, someone who's using a drug for the first time will have a very different experience to someone who's been using it for a long time. And the setting is about the physical and social environment. And, some people might be able to use cannabis quite, well at home, but then as soon as they go into a different environment where there's lots of people around, they might get anxious and paranoid. Or if they eat the drug versus smoke the drug, it might have a very different type of effect. So this is a really important concept to understand. So this is basically going back to Drugs 101. So this is the effects that different drugs will have is dependent on what type of category they're in and about how they'll affect the central nervous system. So the psychedelic drugs, when they're taken, and you can see how many of those are in that category of psychedelics. The main ones that we probably know of that are around is the LSD or psilocybin. MDMA can have both stimulant and hallucinogenic effects. Cannabis also has overlapping, drug effects. As you can see, depending on, what type of cannabinoid it is and whether or not it's eaten versus smoked, it can also have a very different type of effect. And we also have a lot of, and you'll see a lot of names of drugs there that you probably have never heard of. And a lot of these are what we would call research chemicals or new psychoactive substances. So these would be the cathinones like methadone, melatonin. Then we've got, BZP and the cathinone drugs. And then we've got cocaine-like drugs. So what these drugs are doing is they're mimicking the effects of the old school drugs. Now, the European Centre for Monitoring over in Portugal has now found that there's, as I was saying before, about 1,100 drugs that are available, and these are like research chemicals. And they're technically, you might have also heard of them, called legal highs. And these drugs are basically, what they've done is they've tweaked the molecules so that they're not necessarily seen as an illegal drug because they haven't been classified under the UN Drug Convention. But a lot of these drugs are a lot more dangerous than the old school drugs like MDMA and cocaine. So the ones that are trying to follow those or mimic those effects tend to be a lot more dangerous. A lot of these are just bought online. There's been no quality control. There's been no research on these drugs. So, but they are a lot more available than they used to be. Certainly 20, 30 years ago when I started in the field, we didn't have any of these new type of drugs available. So the psychedelics or hallucinogenic drugs will distort the messages to the central nervous system. Now, a lot of people are unlikely to become dependent on these drugs. They're not drugs that are necessarily used kind of daily. Whereas the stimulant drugs, which includes for the main part, MDMA, cocaine, and drug like methamphetamine or ice, these drugs will speed up messages to the central nervous system. So that means your blood will pump faster, your heart will pump faster. You're more likely, if you have an overdose on these drugs, is to have a heart attack or a stroke. But the most dangerous drugs for overdose are the depressant drugs. And basically that's because these will slow down your breathing, it slows down your heart rate. And so people can get into respiratory distress and basically forget to breathe and overdose. So we have quite a lot of the main drugs that people are dying from are the depressant drugs in that respect as far as overdose goes. So, and usually it's two or more of those depressant drugs together. So, we find that a lot of people who might be using opiate drugs might mix them with alcohol or Valium or other benzodiazepines, and it's like a double depressant effect on your central nervous system. So I'll talk a little bit more about that when we look at drug deaths in a minute. But you can see here that there's a lot of drugs that are have overlapping effects. So this was just something I got yesterday from Twitter. It's been a lot more updated than it used to. Okay, so the harms of drug use, we can see that some of these harms are acute problems that will happen, from intoxication. A great example of that is if someone's had too much alcohol, because of the disinhibiting effects of alcohol. If they have too much of it, they can, and it's slowing down your ability to be able to do things properly. People can, trip over, they can have an accident, and that can be either in a car They might also experience violence. They might also do risk-taking behaviour that they wouldn't do because they're not under the impact of alcohol. We can also overdose from alcohol. So we have one young person dying every week of having too much alcohol. And this is basically because young people metabolize alcohol a lot faster than older people. And they're also just not used to their effects. And a lot of people, we have a lot of people that become absent from work the next day if they've had a hangover. You don't feel like doing anything except to stay in bed. Then we have the harms associated with regular use. So these are like, liver disease that can happen, or, disease in your lungs, like lung cancer from smoking. Drugs here are also very expensive. Our illicit drugs, we tend to pay about 4 to 7 times more in Australia than European or America or even the UK. So a gram of cocaine might be about $80 over in Europe, where it's more like $350 to $400 here in Australia. It can also have a really big impact on relationships. People might not want to be, in a relationship with someone that's constantly stoned or maybe, drinking every day. We can also have, that young people are taken away from their parents if they're using alcohol and other drugs. And it can also have an impact on our productivity. And then we also have all of the harms that are associated with dependence. And that just means that people are just unable to control their alcohol and drug use, and the alcohol and drug use becomes more important than anything else in their lives. And we'll talk a little bit more about that one as well. So there's also, this is basically looking at the main way that drugs are used, and depending on what type of drug it is, it might be more suited to injecting or smoking, or sort of like swallowing. So the fastest way to get drug into your system, you can see on the left-hand side of the graph, inhalation is milliseconds faster than injecting into getting a drug into your system, but you can see you get a much higher, well, not much higher, but you do get a bigger effect from injection. And injecting is obviously the most dangerous way that you can use a drug because of all the harms that can happen as associated with injecting, like vein damage, abscesses, and etc. And it's also much more dangerous for overdose. So you much more chance of dying of injecting an opiate drug than you would of smoking that drug. So basically, this is how long it will take before the drugs are ingested into your body, either through injection straight into the vein, into the bloodstream, and then hits the different receptors in your brain. When someone might smoke a joint or smoke cannabis, usually within 2 to 3 minutes of inhaling the cannabis, they will start to feel the effects of intoxication. Sublingual, which is under the tongue or in the mouth, is also quite a fast way of getting a drug into your system, as is snorting. So drugs that are mainly snorted would be cocaine, but some people also do snort amphetamines, although you'd have to, or methamphetamine, but you have to crush it up really finely. MDMA can also be snorted, but a lot of people find that it really irritates their nostrils. Shelving or shafting is basically taking drugs either up your anus or in your vagina. And swallowing is the slowest way to get drug into your system because it basically needs to go through your digestive system before you start to get the effects. And this is where people would get into trouble with something like, if they were eating cannabis, for example, they might get impatient because they're just feeling that the drugs aren't working and have another gummy bear or another bit of sort of cannabis cake or a space cake, as it's called in the Netherlands, in the coffee shops. And then they'll go on they'll have a quite intensive effect that will last also a lot longer. Transdermal, so that's like a good example of that is the NRT patches that people might take if they're smokers, or we've got fentanyl patches as well, which are slow release of sort of like pain. So some of them can be a fast or a slow release. It depends. But they're, again, as I said, the main harm with getting a drug into your system is through injection. And that's also because we have people get hepatitis C or HIV, although we don't have a lot of HIV in this country, thanks to Australia being very proactive and the first country in the world to introduce needle and syringe programs, which were government programs. So about 45 years ago, we were leading the world as far as harm reduction attitudes go. We're now lagging behind in many countries, which is a real shame. So I just want to present you with some data on from the National Drug Strategy Household Survey. This is from 2019. We only got the results of this survey last year, so it usually takes about a year before we get the data from it. This is, I just want to say up front, the best data that we have on what's happening in average households across Australia. So it's stratified across different jurisdictions. So, but we also look at sort of higher and lower socioeconomic groups, but it doesn't capture people that are basically in drug treatment or in jail or incarcerated. We interview, so this is conducted by the Australian Institute of Health and Welfare. They interview 25,000 different Australians from the ages of 14 to 70. Now, a friend of mine participated in this survey not last year, but the year before, and they actually do come knocking at the door. And she's one in an apartment block, and it's and she was the only apartment that was run. So it's very random in how it's stratified. I've also got data here from the Australian Secondary School Students Alcohol and Drugs Survey that's conducted by the Cancer Council of Victoria. We were supposed to be in the field in 2020 for this survey, but then of course we had COVID on our doorsteps. It was going to be postponed till next year. Unfortunately, we still had COVID, so they're now in the field collecting this data. So this is a little bit old, so I won't spend too much time talking about it. But we also looked at 12 to 17-year-olds. So these are people that are not allowed to be drinking, obviously, at this time, but looking at their alcohol and drug use over the time. So it'll be interesting to see what's happening there. So I've just got a poll here just to ask you all to think about before I tell you the answer. We actually had some increases in illicit drug use between the 2016 to 2019 survey. So as I said before, we've been collecting this data since the 1980s, and it's conducted every 3 years. So it gives us a really good idea of what's happened with drug trends over time. So just interested to see what people's thoughts are about what drugs might have increased in New South Wales between 2016 to 2019. I'll just give you a second to think about that before I tell you what the results are. It's the first time in about 10 years that we saw quite significant increases with the illicit drug market.
Could cocaine, okay, pretty quickly.
Yep. Amanda, you thought it was cocaine?
Yeah, I thought one of them was cocaine.
Excellent. Well done. Thank you for that. I showed the answer before I got you to participate.
No worries.
Any other ones? These were the main three that increased, cannabis, cocaine and MDMA. Any other ones that you guys might have noticed in your services or what people have been telling you that you might have seen increases in?
We certainly know that we've seen an increase in alcohol, Annie.
Ah, yes. And that's been quite interesting, and I wonder if that's happened during COVID, because and it'd be interesting to see when we're back in the field for this survey so they'll be collecting the data this year in 2022, what's happened as a result of COVID, because all of that data was captured pre-COVID. So it'll be really interesting to see, what's actually happened in average households over that time with alcohol and drug use, because we had very, very mixed results with some increases, some decreases, depending on the market. But there was a lot of hypothesizing at the time, because particularly drugs like cocaine and MDMA and methamphetamine are not manufactured here. They're all imported into the country. And with 98% of flights cancelled, and that's how a lot of drugs come into this country, we expected there to be really significant impacts on the markets. And we did see some reductions in methamphetamine or ice at the end of last year. but that all seems to have returned to normal, and some jurisdictions saw it more marked than others. Okay, well, look, let me just show you a graph of sort of like how things increased with the illicit drug market between 2016, 2019. So this is just in New South Wales, but this trend was largely seen over all of the jurisdictions. So, you know, cannabis had been dropping off. You can see it was under 10% and now it's got up to 11. MDMA also, or ecstasy also increased up to 3%. Methamphetamine, we saw a slight increase. So these are the amount of people that reported they used the drug last year. And so in inverted commas, these are considered to be a more regular cohort of drug users. But you can see that cocaine, what an increase that is. And I have to say, if we remember, I talked earlier about the 20 to 29-year-old age group. In that age group, it's almost, particularly amongst young men, it's almost up to 1 in 10, you know, people have reported cocaine. Now, traditionally, we haven't had a lot of cocaine in this country. So and most of our cocaine comes in from Colombia. But in the last 10 years, 5 to 10 years, the cartels have realized Australians like their drugs. They're also willing to pay a lot of money for it. So we are seeing a lot more sort of seizures of cocaine and also consequently a lot more people starting to use the drug. Now, as I was saying, you know, the price of it is quite expensive compared to many other countries. So a gram can be anywhere between $350 to $400 per gram. And the purity of cocaine, as I'll talk a little bit more about that one in tomorrow's presentation, is got quite a lot purer in the last 10 years as well. So we also saw increases in hallucinogen use and also saw a doubling in the use of ketamine. Now, ketamine's a drug that's more often than not used in medical procedures. So often post-operatively, people will be given that. Sometimes ketamine will also be used when people, you know, particularly with young kids, when they might have come in an accident to reduce the sort of trauma. Ketamine was used a lot during the Second World War and in what we call battle yard surgery. And it's a really interesting drug in that it's a dissociative anesthetic. So, but it doesn't stop you from breathing. So it's not strictly a depressant drug. So it has both stimulant and depressant properties. So basically you could give enough of this drug to a person. It's also used in veterinary procedures. You can give a drug. So if you were using it in a battle yard context, you don't need an anaesthetist, but you could give someone a dose of ketamine and then amputate their leg and they won't actually be conscious of the fact that that's happening. Now, the difference if people use it recreationally between a good time and being in a really scary dissociative state is quite a small amount. So we get a lot of people that fall into what they call the K-hole if they have too much of it, or particularly if it's mixed with alcohol, then it can be quite dangerous. I guess one of the big side effects that we see with regular users of ketamine, if you have any clients that happen to be using it, is we get bladder and ulceration of the bladder, which can be really problematic, obviously. So what they would recommend harm reduction wise with ketamine is that if you're going to use it, that you leave about 4 months between dosing, you know, to avoid some of those harms associated with it. Ketamine is also used for some alcohol withdrawal, and it seems to be quite effective for that as well. So there's some trials happening about that. So if we just look quickly at the legal drugs here, so we can see that 1 out of 10 people are daily smokers in New South Wales, so slightly less than the national average. Now, arguably, smoking has been our biggest public health success. So in the 1960s, we had about 70% of the male population that were smokers, about 40% of females were smoking. The smoking lobby realised there was a bit of, you know, inequity there, and so started to really market smoking to women. Now we have a high proportion of women still smoking compared to men, but we reduced this quite a lot in Australia, basically by making it harder for people to smoke, like smoke-free workplaces, you know, smoke-free clubs and restaurants, etc. We're also one of the most expensive places in the world to smoke, and currently there's an excise on tobacco that goes up in September every year. by about 10%. So, you know, for anyone who's still smoking, and particularly for people that are lower income, you know, a packet of 50-gram packet of tobacco can cost up to $100. If you buy manufactured cigarettes, like a pack of 30 can be up to $50. So it's really, really expensive. And if you're on a pension, there's not a lot of money left over for anything else. We are seeing increase in the amount of people trying e-cigarettes. And this is particularly, as I said, between the 18 to 24-year-old age group. About 1 in 4 has used it. People are interested in vaping. There was an amazing webinar that was on last week on Positive Choices website. And that's available in the public domain by Dr. Emily Stocking. And it's a really, really good overview of what's happening with vaping, and particularly that with young people. Because of the costs associated with smoking, we are seeing more people using roll your own tobacco. We have seen, interestingly, Gail, and, you know, this is contrary to popular belief, we have seen decreases in alcohol use in Australia between 2016 to 2019. But as I said, be interesting to see what data comes out of the survey next year. So we have about 3/4 of New South Wales people reported that they've used alcohol in the previous year. Some decline in that group, particularly a decline with young people, which has been really good. And again, the alcohol industry has gotten in on this space, and they've started to manufacture, you know, non-alcoholic sort of like gin and non-alcoholic wine and all of that type of thing, just to still keep people, still keep their markets active. But we have, in the last survey, we saw that about almost 1 in 10 Australians was abstaining from alcohol, which is the highest proportion we've ever had. But this is much higher in the young people's group. So we still have almost 1 in 4 people drank in excess of a single occasion drink at least monthly. So that means that they were binge drinking, and a binge drinking episode is considered to be 5 standard drinks in a row. Almost 1 in 6 people used an illicit drug in New South Wales in the last 12 months, slightly less than the national average. This drug was more likely to be cannabis. And this has always been the most popularly used illicit drug in Australia, although, as you know, as many of you probably know, cannabis is now legal in the ACT, and it's decriminalised in South Australia and also in NT and WA. And I think in the next 5 years, we'll probably see it decriminalised in most jurisdictions in Australia. We have a lot of people supporting drink checking or pill testing services. It is a great shame that this hasn't been implemented by our government. Who would have thought that a country like Slovenia would get drug checking services before Australia? I worked in the Netherlands for quite a few years on their drug checking, and they've had drug checking programs for about 30 years in place. So the ACT is currently the only jurisdiction that is checking any of their pills. And what happens when you get a drug checking service in place is it often cleans up your drug market. And we almost have 50% of people supporting supervised injecting facilities. And we only currently have 2 of these in Australia. One of them has been operating for 21 years in King's Cross in Sydney. And a couple of years ago, the Victorian government also opened one in Richmond, and they're about to open a second one in the city, where they've still got an active drug market happening. The great thing about these facilities is that in the 30 years that they've been happening around the world, we have not had one person die of an overdose. And this is, you know, one reason that they're a fantastic addition to our you know, way we respond to alcohol. And I wish we'd see more of them. But at the moment, we only have 2 in the Southern Hemisphere, and they're both in Australia. So this is just a little bit of a summary of what's happening with drug trends, like nationally. So we are seeing increases in roll your own and e-cigarettes. We are seeing more Australians giving up their alcohol, and a lot of this is driven by their kind of health concerns. I don't know how many people realise that alcohol is actually considered to be a Group 1 carcinogen. It has been for 30 years. It was classified at the same time as smoking was, but the alcohol industry doesn't want you to know that the links between cancer and alcohol. And we have at least 1/3 of alcohol-related deaths in Australia are related to people developing cancer as a result of their drinking, particularly of the esophagus and the mouth and the throat. But we also see it, increased risk of breast cancer for women. And we're also seeing, linked to bowel cancer as well. So the less you drink over a long time, the better. We are seeing, illicit drug use falling also amongst young people. This has been a phenomena that's been noted not only in Australia, we've found it in Europe and the UK as well. However, people in my age group, the 40 pluses, are still continuing to use cocaine and cannabis and MDMA and hallucinogens. So, drug use is no longer necessarily a problem of the young. It's also, particularly, and these were people that were binge drinking 20 years ago and doing illicit drugs then and are still doing it in their old age. So the reason that we're seeing decreases in, alcohol and drug use amongst young people is driven by a number of factors. More education that's happening at schools, their parents are better educated. They're also much more involved with social media than we were, and they're living at home a lot longer. So there's a number of things that are driving this phenomena. And every now and then you get a healthier generation of young people, and that seems to be young people growing up now. They're also having less sexual partners than people, that are 40 years plus too. So there's some good things that the young people are doing. We're seeing less non-medical use of pharmaceutical drugs, and a lot of this they believe was was because codeine was reclassified in 2018, which meant that you now need a doctor's prescription to be able to access those drugs. We've seen some few wins with First Nations people, so there's less smoking and drinking at risky levels in those populations. We are seeing large, as I said before, we're seeing smoking rates increase with socioeconomic disadvantage. So it's the poor people that are still smoking in Australia. So we've done a really good job of getting rich white people to stop smoking. We're not doing so well with the poorer people in Australia. So we have very high levels of smoking still in with people with mentally ill health. With First Nations people, with people living in rural remote area, and also people that are on pharmacotherapy programs. Seeing less smoking and drinking in the LGBTQA plus generations. In this survey, we saw more people support cannabis legalization that opposed it. So, again, the public are leading the public opinion here. We're not necessarily, governments are really, I guess, feel quite scared about changing legislation around drug use for fear of being called soft on drugs. And again, 2/3 of our money in Australia that's spent in under the National Drug Strategy goes to law enforcement, and about 1/3 goes to treatment. And a lot more people would like to see more education and treatment funding than straight law enforcement. So it'd be interesting to see if this changes over time. So just talk quickly about the ASAD survey. I'm not going to spend too much time on this one because, as I said, it's quite old data. But you can see this is the data around tobacco smoking. You can see that a lot of young people did roll your own tobacco as well. Again, this is mainly driven by health concern. About 13% had ever vaped or used e-cigarettes. But again, we know from the National Drug Strategy Household Survey that it's about 1 in 4 had used it in the 18 to 24-year-old age group. And again, the reason that people are vaping is that it's very much marketed at young people. It's seen as a cool kind of gadget. We've seen about 1 in 10 say that they used a shisha or water pipe. So this is like the hubbly bubbly that's quite kind of used a lot in Middle Eastern populations. Now, quite interestingly, again, this is kind of marketed as, with with fruity flavors and stuff. And 1 hour on a shisha pipe is the equivalent of 100 cigarettes in lung damage. So again, just because it's sort of marketed as healthy doesn't mean it's necessarily good for you. We are seeing higher rates, again, of tobacco smoking amongst young women. With alcohol use, so these are young people that are not officially allowed to be drinking yet. You can see that 6 out of 10 had tried alcohol while they were at high school. Almost half had used alcohol in the previous year, and about 1 in 10 had used it in the past week. But as I said, this has been decreasing over the years. So it'll be really interesting to compare this data with the new data coming out this year. We are also seeing binge drinking. So about 10% of 16-year-olds reported that they'd had 5 drinks or more, and slightly higher amount for the 17-year-olds. And, the vast majority, the drink of preference is the spirits or the pre-mixed spirits, so the harder stuff, which is quite concerning. And this statistic is also quite concerning. Almost half of people got alcohol from their parents. Why this is concerning is because, if parents are giving you alcohol, you're more likely to become a binge drinker, and you're also more likely to develop problems around alcohol use. So, the moral of the story is, if you're a parent, is please don't give your child alcohol, because if you give them alcohol, it presumes that it's okay. There was a really good study which is coming up in module 2, which I'll talk about, where they basically tried to look as if we tried to implement a more European style of drinking, where you drink with food rather than drink to get drunk, to see whether or not, if people modelled better behaviour at home, whether or not that would reduce young people's alcohol use. And they looked at sips of alcohol versus full serves of alcohol that were provided by parents, and they still found pretty significant outcomes in relation to binge drinking. So moral of the story is don't give young people alcohol before their age. And I think if we had a time again, and New Zealand saw this very much up until 1999, they had a drinking age of 20. They reduced it to 18. And they basically found that they saw more risky drinking happening amongst the 16 to 17-year-olds, as well as riskier drinking in those new drinkers. So they wish they'd kept it at 20 years old. So this is ever used illicit drugs. So this is, they've tried it in their lifetime. So quite high levels of cannabis use. About 1 in 20 reported that they'd used MDMA. About 1 in 33 hallucinogens like LSD or magic mushrooms, methamphetamine or ice. About 1 in 50. 1 in 50 had also tried cocaine. It'd be really interesting to see if that's also gone up. And about 1 in 100 had said that they'd used heroin or opiate drugs. And the older you are, the more chance you are of trying these drugs. So lower levels of use, obviously in the 12 to 13-year-olds, and higher levels in the 16 to 17-year-olds. So just quickly looking at First Nations data. So, we are more likely, First Nations people are more likely to abstain from alcohol than other Australians. And about, 15% reported that they didn't consume alcohol at all. But those that did drink, you can see that, about 1 in 5 First Nations people reported drinking 11 or more standard drinks at least once a month, which is really kind of concerning for health. Our guidelines currently say that we should only have 10 standard drinks per week and have 2 alcohol-free days per week, and not have more than 2 to 3 drinks on any occasion, maximum of 4 on any occasion. So the less you drink over a lifetime, the better the health outcomes would be. So these guidelines were just revised in 2020. They're revised every 10 years. And for those of you who might have been in the field for a while, you might remember that men could have up to 24 standard drinks in the 2001 guidelines. So 20 years later, that's halved, less than halved. And they haven't made a distinction between genders there. And as I said before, smoking rates are for Indigenous or First Nations people living in non-remote areas was about 40%. and in remote areas, almost 60%. So this is an area we really need to do more work. And one of the things I talk about in the module next week is just around, you know, whether or not they're doing some really good studies over in the US and Europe where they're paying poor people to give up alcohol, give up smoking, and supported with counselling. And I'd really like to see some of those interventions happening over here. About 1 in 4 First Nations people reported that they'd ever used an illicit drug. That was also more likely to be cannabis. 1 in 5 had used pharmaceutical drug for non-medical use, and about 1 in 30 had used methamphetamine. So we do have in some communities quite high levels of methamphetamine or ice in these groups, and it really, I think, arguably of all of the drugs, is the one that's you know, most devastating to manage within a family context. So this is a study looking at people accessing needle and syringe programs. So as I said before, these programs have been up and running in Australia for about 30 years. These are results from almost 5,000 people. So this is basically, this survey happens every year, and researchers, I've also participated in carrying out research for this survey. Basically sit in needle and syringe programs, ask clients that are coming in if they'll fill out a 10-minute survey. And this is some of the data that we got. So almost 20% of those accessing needle and syringe programs identified as Aboriginal. The average age was about 41, but you can see they're quite a disadvantaged group. So there's high rates of homelessness, there's high rates of mental health, also imprisonment, and also people that are on opiate substitution therapy like methadone or buprenorphine. About half had reported that the drug that they'd recently injected was an opioid. 1 in 3 reported it was methamphetamine or ice, and 1 in 7 had reported injecting performance and image enhancing drugs or steroids. And they're not always injecting daily, but about 40% reported injecting daily or more often. Even though we have needle and syringe programs operating, you can see that still 1 in 5 reported sharing injecting equipment in the previous month, which is not so much dangerous for HIV because we have very low prevalence of that in our population thanks to the introduction of needle and syringe programs, but it is concerning with hepatitis C because it's a much more virulent virus, and about 50 to 60% of the current injecting population in Australia is estimated to be infected with hepatitis C, although we have some amazing new treatments with Hep C. So if you have clients that are injecting or have had a history of injecting, have a conversation with them around hepatitis C and getting on that treatment program. It's one of the great things that was introduced in 2016. It has virtually no side effects, the treatment, and people tend to do really well with clearing the virus. And it's a lot more, some people, they used to treat people with interferon, and people that wasn't that successful and people got really sick. It was a bit like kind of chemotherapy drugs, but now it's really, really great treatment. Okay, so now we're just going to look at some harms of alcohol and drugs. So there was a survey that was conducted a couple of years ago in Australia, which was a replica of a survey that was done in the UK. And it basically sort of asks, according to alcohol and drug experts in Australia and around the world, which drug do you think is most important or most harmful to society? And interestingly, the UK and Australia came up with the same drug. Which one do you think it might be? Anyone like to have a guess?
Nicotine.
Came in at number 4.
Okay.
Yeah, but good guess. And I think it's definitely the drug that kills most people in Australia. Like we have 18,000 deaths, over 18,000 deaths a year associated with it. And it also has really significant, about 22% of the cancer burden is taken up with nicotine. So, but interestingly, it wasn't nicotine.
Wouldn't it be alcohol?
Well done, Amanda. It is alcohol. Yeah. And this is basically the results of the Australian study. So what they did is they got 20 alcohol and drug policy experts and addiction specialists in a field, in a room over 2 days. They mapped the 20 most popularly used drugs, which are listed there on the screen in front of you. and they looked at what the harm to, and they measured it on the harm to the user and then the harm to others. And I'll just flick to the other side for a second so you can see how they mapped it. So there was an overall harm. They looked at the physical, psychological and social, and then harm to others. They looked at the physical and psychological, and then the sort of social harms associated with it. So this is a paper that's in the public domain. If people are interested, please contact Gail and I'll send a copy of it to you. But you can see here, top of the pops. So you can see the greatest harm to others was caused by alcohol, which is listed in the red. So this was number one. And crystal meth, you can see came second, and it's got really significant harms with the users. So the blue graph, the group blue one is basically collecting points on the harm to users, and the red is harms to others, so family, friends, society, etc. Cigarettes, sorry, I got that one wrong. It's number 5 rather than number 4. Fentanyl is number 4. So fentanyl is a synthetic opioid drug. This is what's causing a lot of the opioid crisis over in America. We don't have a lot of fentanyl to date in our drug supply, which is a good thing. But fentanyl is estimated to be 80 to 100 times stronger than morphine, which is why we're seeing, so much overdose over there, particularly in the US, where there's a lot of it, and Canada in their drugs market. So if you're working with clients that are injecting opioid drugs, we have what's called fentanyl strips that are available from a lot of needle and syringe programs, or the New South Wales Users and AIDS Association, where people can test their dose before to see whether or not it contains fentanyl in it. The great thing that we have in Australia, which is basically available to all people that are using opiate drugs, is naloxone or Narcan, and it reverses the effect of an opiate overdose pretty well instantly. It takes about 2 to 3 minutes to reverse the effect of an overdose. So that's a really good thing and a lot of NSP programs in New South Wales. So the government subsidised this program is providing this, and it's a nasal form of it. And basically you just put one, puff of it into the nostril, and within 2 to 3 minutes, what it does is it knocks the opioids off the receptor and reverses the effect of an opiate overdose. So at the end, we have electronic cigarettes down here, and kava and LSD and MDMA are also quite low levels of harm associated with it. Is anyone surprised by this graph, or anyone got any comments on this that they'd like to discuss? It's quite interesting because, as I said, this was a copy of a study that was done in the UK 10 years earlier, and crystal methamphetamine came in at number 18 on their survey compared to number 2 on our survey. And the reason for that is that it's not very popular. They don't have a lot of crystal methamphetamine over in the UK, whereas we have a lot more of it available. So where you are geographically situated in the world can also determine your drug market. And crystal methamphetamine, we're some of the biggest users of crystal methamphetamine in the world, unfortunately, here, and we have a lot more of it available. And it does certainly, as I said before, it's arguably the most difficult drug to manage within a family context. All right, let's look at the number of people. So this was some study that was done by Chen and Anthony, and then Lopez and Chinquero looked at it again, and they estimated, of the amount of people that ever tried a drug, how many would become dependent on it. And you can see top of the pops, the most addictive drug of all is tobacco. So it's the nicotine which keeps us smoking. However, it's the tar that actually kills you. And I think that's a really important distinction to remember with tobacco. It's the smoking of it which produces the tar, and the tar that is most dangerous. So heroin or opioid drugs are about 1 in 4 or 5 people who try them, and cocaine is also very addictive. So that's why, and a lot of my colleagues that are working in the field are really, really concerned that cocaine is the second most popularly used illicit drug after cannabis in Australia now, which has bumped MDMA off the list. So it comes in. We don't really have anyone accessing drug treatment for inhalant or hallucinogenic drugs. So there's these drugs are more likely to be used on the weekend rather than a daily level of use. But crack cocaine, cocaine is really quite high in dependence. So if you get to the point where you are injecting cocaine, because it's a very, very fast acting high, and if you smoke it or you inject it, the high will last about 15 to 30 minutes. Then people, might be, if they're injecting up to 20 times a day, and you can imagine the harm that you're doing to your veins if you're injecting that much. We don't have crack cocaine, or it hasn't really been found in Australia unless people are buying the cocaine and then making it themselves. So crack cocaine is more addictive because it's smoked and it lasts a lot shorter, as I said, same as in injecting. And you tend to get crack cocaine when you get an oversupply of cocaine, and we haven't had an oversupply yet. Fingers crossed we don't get there. But as I said, a lot of drug and alcohol experts are quite concerned about that. So these are just looking at drug-related deaths. So you can see the main drugs that are killing Australians are the legal ones. And I think probably if they had our time again, we probably, well, personally, I believe we should decriminalise all drugs, because a lot of the harm that happens with drugs is people ending up in the criminal justice system and getting a record and ending up in jail, really. And when someone is dependent on a drug, rather than to be punished, they need to be supported. So you can see the other illicit drugs. We've actually had some more recent data that's come out that we've got other illicits that have increased to about 2,200 deaths. That came out last year. But most of these deaths that happened with the illicits are accidental. And you can see the opioid drugs. So these are basically the pharmaceutical opioids. They were present in 3 out of 5 drug-induced deaths. We had a very, in about 2000, we started to see that there was hardly any heroin coming into Australia. And then we've started to see amount of heroin coming into Australia gradually increasing since 1997. So we've started to see more drug deaths associated with heroin. And I'll talk a little bit more about that one in module 4. Quite a few of the deaths also involved benzodiazepines like Valium or Xanax. We also had quite a few deaths associated. ATS stands for amphetamine type stimulants. So that's basically methamphetamine. And we're also getting more deaths associated with cocaine in Australia. And as we have more people starting to use it, we will also start to see an increase in the amount of deaths. Looking at drug-related hospitalizations here. Now, there's a lot of information on this slide, and I'll give people a copy of the presentation, PDF copy of the presentation. But I thought this was really interesting, the box down here that I've kind of highlighted. And you can see that the main drugs that are killing people in the major cities are opioids. When we go into, our regional areas, it's more likely to be amphetamines and other stimulant drugs. And then if we look at remote and very remote communities, it's more likely to be cannabinoids and cocaine, again, more associated with it. So I thought that was just really interesting, qua the geographical locations of hospital admissions from those drugs. So another question for you, and this is a bit of a no-brainer. Which drug do you think most people are seeking treatment for in Australia? What's the biggest demand on treatment, drug treatment? Any guesses?
Alcohol.
Oh, well done, Gail. You've done your homework. Alcohol makes sense because it's also the main drug that people are using. So, if we see more people using that drug, we'll start to see more people getting dependent on it. Got another question for you guys while we're on this one. Is anyone like to estimate, and this is Australian data, how long it takes someone to access treatment for their alcohol problem from whence the problem begins. And it's a number of years. Would anyone like to guess how many years that might be? 18 years before someone, from when the problem first develops. And a lot of this is driven by stigma and discrimination. And again, you know, and being fearful about accessing treatment and being ashamed of their dependence. So again, you know, the more we can reduce, you know, stigma and discrimination towards people that use drugs and accept it as something that's quite normal, but also provide treatment and support, the better it is. So this is some data that's collected from the national minimum data set, which every jurisdiction has in place, you know, for the amount of people that access drug treatment in Australia. We have around 200,000 people that are that have basically got treatment for their alcohol and drug use in a year, but it's estimated to be double that want the treatment that basically can't get it. So that's a real sort of shame. And that's where people that are working in the field, and you guys might have experienced this yourself if you tried to facilitate clients getting into treatment, that there's not treatment available when they actually need it. It's really cost effective. And there was a great article that was published in yesterday's paper. Again, I'm happy to send that to Gail if people are interested, that talks about successes with treatment, and that for every dollar that we invest in alcohol and drug treatment, society gains $7. So law enforcement is a lot more expensive than basically treating the problem. And basically, can we reduce the stigma and get people into treatment earlier, there's less harm that will happen to the individual, but also to society, and the more cost effective it is. Now, not everyone needs rehabilitation. Most people do quite well with just getting some counselling, you know, if it's available, and you can see that that's the main form of drug treatment available in Australia. The main drugs that people are seeking treatment for, so almost over a third of treatment episodes are for alcohol. Now, interestingly, you might remember that about 1% of the population reported using methamphetamines in the previous year, but it's the second most common drug that people are seeking treatment here. Now, remember I talked about takes up to 18 years for people to access treatment for alcohol. For methamphetamine and other drugs, it's more likely to be 5 to 10 years. And a lot of what prompts people to get into treatment for methamphetamines is experiencing psychosis. So about over 1/4 of our treatment episodes are methamphetamine. So even though we have low levels of use, those that are using it really problematically and are needing more sort of support for that. But for the 20 years that we've been running this study, cannabis was the second most popular drug for a long time, and methamphetamines for the last 5 years has overridden that trend, and it's more likely to be amphetamines. But interestingly, when I started in the field 30 years ago and you rang up a treatment centre and wanted support for cannabis, people didn't think you can even get dependent on cannabis. And it was the response was almost like, come back to us when you've got a real problem, drug problem. But you can see here, it's the third most popular drug that people seeking treatment for, and opioids are the fourth drug. And we have about, just under 500 publicly funded services that are included in this sample. Okay, so this is an exercise that we would do online if we were in breakout rooms, but we're not going to kind of do that. But I just want you to think about this one a little bit more. And this is really just to get people to reflect on, which drugs and drug situations are most concerning to you. So you have 9 different types of drug people who use drugs on this slide, going from 14-year-old smoking cannabis at a party right through to a drunk woman at home with her children. And what I would normally get you to do is rank them from 1 to 9 and then break up into small groups and discuss which ones you think are most concerning. But we don't have time for that one today, but this is a really good activity to think about. And I guess, the moral of the story is that a lot of people will make value judgments about these situations depending on their experience and and I guess, you know, maybe they've got a 14-year-old and they sort of think, well, cannabis is really kind of concerning for me at this point in life. For me, if I rank these, the top three in this group, I would undoubtedly say 16-year-old injecting heroin on the street is most concerning for me, because of the drug that she's using, the way she's using it, injecting. Also because her age, you know, she's got a lot of vulnerability there. You know, she's on the street. She's, you know, that one single drug situation could be death out of all of them. The other ones are definitely concerning. My second most concerning one would be the young man injecting methamphetamines or ice in a public toilet. And then probably somewhat surprisingly to you guys, the next one that I find most concerning is the businessman staggering drunk out of a bar. Most people rate this person as number 9, but I think there's quite a lot of harm that can happen as a result of that one. There's technically no right or wrong. And I guess if we're looking at a hierarchy of harms and about where we would intervene, but we all make judgments. We don't have a lot of information about these people. Often the one that always comes up for people in their top 3 is the drunk woman at home with her kids. And I guess, you know, the question here is like, how drunk is drunk? Is there another adult around? How old are the children? So a little bit more information would make it much easier for us to rank these situations. Has anyone got any comments or questions about this, or ones that they would rate differently from what I'm sort of saying? Oh, you're all silent. All right, well, go on.
Late in the afternoon, Annie, we can see it getting dark.
It's time to finish up. Okay, well, what I'll just do is just finishing up with a sort of like, please check yourself about what you bring to your situations with people who use drugs. As I said, stigma and discrimination stops a lot of people from accessing treatment. The language we also use is really, really important. And you can see from this slide that, you know, 4 out of 5 people who inject drugs have experienced discrimination from healthcare providers. We need to like, you know, junkie, and you know, and again, really important to see the person and not the drug or the you know, or their mental health, or define them by that. They're a person first, and let's not label them by what we see. And you can see, again, these are some of the impacts of stigma and discrimination. You know, they're delays in not seeking treatment. They don't access needle and syringe programs. They might not call an ambulance. They might not access healthcare, you know, for fear of just, you know, being seen as a, you know, as someone who's unworthy of treatment. And they might be reluctant to raise their issue, or, you know, have poor self-esteem, and maybe even, you know, increase their use to cope with the stigma of discrimination. There is a really great brochure that was produced by the New South Wales Users and AIDS Association, and also NADA, which is a network of alcohol and drug services, New South Wales alcohol and drug agencies. And this guide is online, and you can see the PDF that you can get there. You know, avoid words like abuse and misuse or problem. You know, again, they're all buying into that stigma stuff, you know, so if we can try and use these type of words, and even, you know, and a lot of people might go through 12-step programs will often use words like, you know, addict and junkie and, you know, clean and sober and all of that type of thing. But I guess, you know, if you say you're clean, then conversely, it basically means that someone who's using is seen as dirty. And all of this impacts, you know, the clients that we're talking about. So try to check your language and change it if you can. And you know, there's a lot more there's a lot more resources available, but these are the main terms that I would you know, suggest you use instead of the other language. So I guess, you know, there's some good news stories in what we've presented today, you know, and that's basically, you know, the good news stories is amongst the young people. They're using much less alcohol and drugs, and especially alcohol and tobacco than probably their parents' generation was. We are seeing some increases, as I said, in illicit drug use, particularly amongst people aged 40 and over. We can look at the harms of alcohol and drugs in, you know, the propensity for overdose, the amount of people that die from them, the relative addictiveness of them, and the route that they're administered. And arguably the main problem is injecting there. And also just remember that the main drug that is our number one issue in Australia and around the world is alcohol. So don't forget to check in on that. And I think it's really just on that. Alcohol is one of the most heavily marketed products in the world. And I'll talk about that in session 2. And, you know, they'll get young people through social media, through sports advertising and sponsorship and all of that type of thing. And it's quite subversive. And often when you go to an event, it's easier to get an alcoholic drink than a non-alcoholic one. And we also need to stop the advocacy of, alcohol products happening in our public policy in Australia, and probably get rid of it in Parliament House, because in every other workplace it's banned, but that one it's not. Any questions or comments before we sign off for today? No?
Doesn't look like it, Annie, but thank you. It's always a very thorough session when we speak with you as well. So please jump in if you do have any questions, last opportunities, or pop it into the chat box, or just give us a quick comment on what you felt about the session that Annie's delivered for us today.
And I'll just, while people are thinking about that, I'll just flick through some really good websites. And again, these slides will be available for people. But don't forget about the Alcohol and Drug Information Service, ADIS, which is a 24-hour advice and counselling line. And they can also provide information on where to find treatment or local treatment services in your jurisdiction. One thing I do want to really point out for people is there's a lot of great information available on the ASSIST, which stands for Alcohol Substance Use Inventory, test. Test sounds a bit too, but this is a tool that I talk about in module 4 of this series. But on their website, under assist tools, there's under training resources, there's some really great fact sheets that I produced with the University of Adelaide a couple of years ago, based on the, what drug is that? And I talk about the different street names, what it is, what it looks like, how it's taken, short-term and long-term effects, other things that you consider, and some harm reduction advice. So if this is really great thing to have in your toolbox, and we've got 12 drugs that I've researched in that time that are available, and these were developed for clinicians to assist with doing the assist, which is a great screening tool that looks at all about 10 different types of drug, and it screens, and it gives you a score at the end about how to deliver a brief intervention about those. And this is really valuable information. So if there's one thing you take away today, please download these sheets. And it's only been printed last year, so it's the latest evidence-based information around it. New South Wales Health also has a really good website on Your Room, although there's not a lot of harm reduction information, which is why I'd recommend the Assist website for better. The Alcohol and Drug Foundation also has some really good information available, and they produce a lot of resources. They've got a great one about how to have a conversation with someone about drugs, so it's good to go there. If you've got clients that are, want further harm reduction advice, this is from Harm Reduction Victoria. They've got some good brochures and available information online. And then also DanceWise, which is available from the New South Wales Users and AIDS Association. This is Australian information. They've also got some fantastic harm reduction information available. They also do regular drug alerts because we don't have drug testing in Australia. So whenever there's a person's had an adverse effect from a drug, they'll provide some information about it. So you can also follow DanceWise on social media. It's a good way to keep up to date with adulterated drugs online while we don't have the drug testing services. And then a lot of the information I presented today comes from this book, which is also available online. And that's it.
That's wonderful. Thank you, Annie. Are there any questions for Annie before we go? No, there's dark backgrounds behind a lot of people. So
It's 5 o'clock, so it's time to knock off.
A great session. Thanks, Annie.
Thank you.
Thank you,
No
Annie.
problem.
Appreciate it. Bye.
All right.
Thank
Take
you.
care. Pleasure.
Thanks.
Thank you. Bye.
Bye.
All right. I'll stop recording, Gail, now.